And the next presentation that we have will be from Alan, who will talk to us about population level estimates of hepatitis C reinfection post scale up of direct active antivirals amongst people who inject drugs. I'll pass you over to Alan.
Yep, thanks. Sorry about the long title, but I'll try to just present or share the slides. So I'm hoping that that's worked. So yeah, thanks. My name's Alan Yeung. I'm a research fellow at Glasgow Caledonian University and currently a healthcare scientist at Public Health Scotland because of COVID, but normally I'm an analyst working on BBV STI things. It's going to talk a bit about a study we've done looking at hepatitis C reinfection post scale up of direct acting antiviral treatment among people who inject drugs in Scotland. This work was just published in Journal of Hepatology, and of course it's a big team effort, so I've listed all of the co-authors that helped to do this study there as well. So to start with some background. So the World Health Organization set a target of Hep C elimination, which involves reducing HCV incidence by 80% by 2030. And Scotland aims to do this by 2024, which is pretty ambitious. So an important aspect to achieving this goal is to monitor reinfection, just to make sure we know we're actually achieving this. People who inject drugs are a priority group for elimination because many people who inject drugs also have hepatitis C. And in particular, scaling up direct acting antiviral treatment is important because we know they adhere well to these treatments, whilst they didn't previously to the old interferon treatments. There's still quite a lot of uncertainty around the levels of reinfection post-DAAs because there's not that many large-scale studies done to date on this topic post-DAAs. Certainly not many national ones, so this is one of the first studies in that area. So as mentioned, treatment scale-up is an important aspect of achieving elimination. So this chart here just shows the sort of level of treatment scale-up. We split the study up into 4 time periods: 2 pre-DAA periods, 2000 to 2009, then 2010 to 14, which relates to a sort of period of modest treatment scale-up to do with Scotland's Hep C action plan. Then we've got 2 DAA periods, the 2015-2016 period, which relates to a period where treatment was prioritised to those with advanced liver fibrosis. And then the sort of final period there, 2017-18, which relates to sort of wider scale up where treatment was rolled out more widely. So as you can see, those time periods are not evenly split. So I've actually got the average number treated per year on the y-axis. And you can see that there's been considerable scale up from just under about 300 per year in 2010 to 14, tripling to just under 900 per year in the most recent period there. You can also see a sort of big change in the types of settings where they're being treated, away from hospital to more community and prison settings. So I've got another table here, which is just to emphasize that idea again. I've highlighted in red a number here for 2017-18 in Tayside, just to show you that actually 3/4 of the patients treated were in fact treated in community settings. So they're really going after these sort of patients with higher risk of infection. So using record linkage of established sort of Hep C clinical and laboratory surveillance systems held in Public Health Scotland, we had three main aims. Firstly, to provide the first population level estimates of Hep C reinfection since the introduction of DAAs in Scotland. Secondly, to provide a comparison of reinfection rates pre and post DAAs and by setting of treatment to get an idea around the variability around the rates. And finally, to estimate the extent of undiagnosed reinfection, focusing on the DAA period because this involves a bit of guesswork, and the further back in time we go, the more you're sort of guessing. So we wanted to focus on the DAA period for this work. We used a very straightforward definition of reinfection for this study, which is just any positive Hep C RNA or antigen test identified during follow-up post-SVR. So this flowchart shows how the study cohort was made up. So we started by using the data held in the Scottish Hep C clinical database. We identified people with an injecting history there and looked at all people who initiated treatment between 2000 and 2018 and achieved an SVR. We restricted it to those treated from clinics in Glasgow, Grampian, Lothian and Tayside because we have comprehensive Hep C testing data for these areas. And in fact, these areas cover about 70% of people who inject drugs that have been treated for Hep C as well. So in total, we found 5,686 SVRs among 5,592 people. And you'll notice there's more SVRs than people here because some people get reinfected more than once. We got high linkage rates to the test database, about 98%. The next part involved identifying a sort of confirmatory SVR test, which is just a negative Hep C test post-treatment. So for those treated in 2013, we looked for a negative test around 24 weeks post-treatment. And for those in the 2014 to 2018 period, we looked for a negative test around 12 weeks post-treatment. And these relate to the SVR 24 and SVR 12 periods. So overall, we confirmed SVR for 90% of these people. The rate was 82% for the SVR 24 period and 95% for the SVR 12 period. But the sort of biggest dropout for the cohort comes from looking for those with at least one Hep C RNA or antigen test after confirmation of SVR up to the end of 2019, which is the end of our study period. For there, we have a bit of dropout. 4,126 are left, which was 73% of all the SVRs. And that's the sort of study cohort we use to estimate reinfection. So here we've got the cohort characteristics. On the left column is the kind of top of the flowchart I just showed you, the 5686. The middle column is the number with a confirmatory SVR test. And on the right is the sort of numbers relating to the bottom of the flowchart, the 4126. From here you can see the sort of treatment scale-up effect again. So most people treated in the 2017-18 period, about 30%. And I've got in red here the fact that there is a reasonable amount of dropout when we consider only those with at least one follow-up test for reinfection. So 6 to 8% there. We can also see over half are from Glasgow. But again, I'm highlighting Tayside because we could only follow up half of the people there for reinfection. Over half again treated from hospital, but a sizable proportion treated in community settings, about 20%. But again, only 66% could actually be followed up for reinfection. So more characteristics, about 3/4 were male, most were aged 35 to 49. But again, we've sort of got lower follow-up rates with younger age, only 66% among those aged less than 35. About 20% we identified as having cirrhosis at the time of treatment. And we actually linked to hospital admissions data to get some kind of indication of ongoing injecting risk, because we didn't have this data available in the Hep C clinical database, unfortunately. So we found that about 20% had a hospital admission for opioid or injection related hospital admission anyway, during treatment or in the 3 years pre-treatment. So overall, we found 361 reinfections over the whole time period among 9,000, just over 9,000 person years of follow-up, which gives us an overall reinfection rate of 3.9. But you can see how that increased considerably over time from 1.5 in 2009 all the way up to 8.8 in the 2017-18 period. We'll also see high reinfection rates by those treated in community settings of 9.5 and 14.3 for those that were treated in prison settings. We also got a measure of risk by putting all of this data into a Cox regression model, adjusted for all of the sort of variables I showed you previously. So there you can see a sort of 3.3 times increased risk for those treated in the most recent period compared to those treated in the earliest period, and also about 1.8 times increased risk of those treated in community settings compared to those treated in hospital, and 3.2 times increased risk for those treated in prisons. So finally, the last aim was to look at undiagnosed reinfection. So the first thing I want to talk about is sort of retesting rates, because that gives you a sort of idea of how much potential there might be for undiagnosed reinfection. So among those treated in the sort of DAA period, 2015 to 2018, we found actually reasonable levels of retesting within the first year post-SVR, just around 70%. But the problem that we found is that these rates dropped off like quite drastically beyond the first year, down to 30% in year 2 and beyond. So that gives an idea that there could be quite high levels of undiagnosed reinfection. So we used simulation methods to sort of get an idea of how much undiagnosed reinfection there might be. The sort of main assumption that we make is that the risk of reinfection during unobserved periods of time for patients is the same as in observed periods. We allowed the reinfection risk to vary by the sort of key factors we found from our model, which were by NHS board, treatment setting and age. So with that, we found potential for around 200 undiagnosed reinfections, which is actually more than the 169 that we diagnosed in the DAA period. And this isn't totally surprising, because in the overall nearly 6,500 person years that are possible if everybody was followed up for the whole time period up to the end of 2019, about 2,600 were observed, so about 3,800 were actually unobserved. So it's quite a lot of time that we don't know what's going on because they've not been tested. And we found a pretty even distribution between undiagnosed reinfection between those treated in the 2 time periods there, and that we split it up by, and also pretty even split between those treated in hospital and community settings. So with that, the main conclusions are that reinfection rates did increase considerably in the early phase of treatment scale-up with DAAs among people who inject drugs in Scotland. Although this is a sort of cause for concern, it does also show us that the community-based treatment pathways that they're using in places like Tayside are reaching these high-risk groups, and that's exactly what we need to do to actually achieve elimination. We also know from previous modelling studies that with a sort of rapid scale-up in treatment, which there has been in some parts of Scotland, we can expect there to be more reinfection initially, partly because there's just going to be more opportunity for reinfection to appear with more people being treated. But we do expect this to come down over time, and we'll have to follow up this study with further reinfection studies to confirm that. But an encouraging fact is that we've got data from things like the NESSE study to show us that the prevalence of Hep C is coming down in places like Tayside with the sort of treatment as prevention strategy that we're employing. Another conclusion is that the levels of retesting were found to be low beyond the first year and need to be improved. Guidelines recommend that we retest those at risk of infection about once a year, and we're sort of failing to do that, so those do need to be improved. So with that, there's potential for considerable numbers of reinfections going undetected. So concerted efforts are needed to ensure prompt diagnosis of reinfection, and when these are picked up, retreatment should be offered promptly as well, and these are all vital aspects of national strategies to achieve Hep C elimination. So thanks for listening. Don't know if anybody has any questions.
Thank you very much for your presentation. I've not have any questions posted. And yeah, and this slightly goes over my head when it's a lot of numbers scrambling.
Yeah, I forgot to apologise that it's going to be a data-heavy talk.
And I don't really want to throw kind of service level type kind of questions at you, because you work as kind of with the kind of population level type things. From maybe I will stress you a little bit then from a kind of more kind of population level kind of analysis of the data. Are there any practical things from your area of work, and the answer could be no, because it's out with the remit of your work, that you feel can be translated into more practical recommendations for services?
Definitely the main thing is to, I don't know how to achieve it, but we're obviously getting this drop off in testing after the first year, and I don't know how we can make sure they're coming back year after year to get tested, just to make sure we can pick up these reinfections that are coming.